Hey everyone, welcome back to the show. In today's episode, we are joined by a good friend of ours, Neil Sheth. Neil is a sports physical therapist who recently published an incredible paper with one of our former guests, Jess Ellis, titled Decel to Excel, a technical framework for introducing deceleration in the clinic. He completed a sports physical therapy residency with Evidence in Motion and is working in Virginia Beach running a new sports physical therapy practice for a large orthopedic group and also running N1 Sports Rehab. He is a board-certified sports physical therapist and certified strength and conditioning specialist. Neil, welcome to the show.
Excited to be here. Thank you for having me, Brian and Matt. I'm just excited to see you guys. It's been so long.
Well, we saw you, Elite Football Rehab Conference a couple months ago, right?
Yeah, it already feels
in a little bit of time. For sure. But it's always good to catch up and chat because I think the paper came out right around that time. Is that correct?
Yeah, I want to say it came out maybe like a week or two after that conference. Like
Okay.
JOSPT accepted it right after that.
That's nice. Yeah, good stuff. Well, listen, Neil, I want to get started here with. I know we all know each other really well, but can you just give us a quick overview of kind of your journey as a sports physical therapist and what led you to your current role right now?
Yeah. Well, I mean, I can go as far back as you want. In PT school, I kind of knew I wanted to be in sports in some capacity. Didn't know how I was going to get there. Ended up interviewing for some residencies. Evidence in Motion is the only one that offered me a position, and that was going to relocate me from Jersey, where my parents lived, all the way to Austin, Texas. So I was like, screw it, I'm going to go. This is what I want. So I did a residency there, which was great learning opportunity, great mentors I had. From there, I stayed with the company I was at, and I moved to San Antonio and kind of ended up running their residency, their South Market sports residency for 2 years, which wasn't part of the plan, but it was a great opportunity. Got to mentor, learn way more about that just made my head hurt working with people and managing like that. Then COVID happened and kind of felt like I wasn't seeing the value in what I was doing anymore, which led to N1 Sports Rehab, like you alluded to. And at that same time, an opportunity opened up for me to move back to Austin and start my own practice, which is how N1 started. I did that for a couple of years, was going really well, connecting with some of the local high schools and colleges there. And then my wife had a really good opportunity to move to Virginia Beach for a really specialized part of optometry. So I was like, we can do it. I can start this over again if I want. So closed up shop. We moved to Virginia Beach and first started out at the Children's Hospital down here, which wasn't part of the plan, but someone who had an opening that hired me. And from there, one of my coworkers left to start a physical therapy practice with a private outpatient group. And he said, when I have the opportunity to start a sports practice, I'm going to steal you away. And I was like, dude, that's not going to happen, but okay, you let me know. And lo and behold, he had an opportunity a year later, reached out, checked out the space, and it was an opportunity for me to do the type of sports rehab that I wanted with high school, college athletes, and also to do some return to sport consulting. And that's how I ended up where I am now.
Nice. So that's been a pretty interesting journey from kind of where you started and where you're at now. And it doesn't sound like you totally planned all that out.
No, I didn't plan any of it.
But it seemed to work out pretty good for you, huh?
Yeah, I mean, I was worried the entire way. I mean, I had the thoughts of going into pro, and obviously that's really tough. Anywhere you are in your career to get into the league at whatever level. So I just kept chipping away, trying to make myself as good of a PT as I could, and just whatever happened.
Nice. So somewhere along the way, you decided that deceleration was going to be your thing. So I want to jump right into the paper with this now. So that paper that you wrote with Jess, it was great, by the way. And I think that it was nice because it was the first time we saw something that was laid out in a really nice framework. Can you tell us maybe a little bit about where that idea for that paper came from?
Yeah. I don't know if my video froze. I just got a little notification about it, but
Nah, you're fine.
okay. The paper, so where it really started culminating, kind of hit like a waterfall, it was actually at the elite basketball course last year, 2024, which pretty sure I saw you there as well.
I think you followed me to every course so far in the last 2 years. Just putting it out there. Oh, we notice. We noticed.
But after the first day, I was talking to Jared Boyd after the networking event. We were just talking deceleration stuff, and I just had this overwhelming urge that I was like, no one's really talking about this, and I do a lot with it in the clinic. So I had this really big urge after I got home from that course that I needed to get this word out. And I reached out to Jess, who's been a mentor of mine for a while, and he was really interested in the idea as well and supported me. And I just, I honestly just locked in. I went to like that flow state and just typed away.
Nice. Now, with what you've done with this paper, what were you trying to achieve with it? Obviously you started typing away. You said, hey, there's this, obviously there's gap that's not being talked about. But what were you trying to really, like, initially, what were you trying to address with this paper? And what were you hoping to get to give other practitioners with this paper?
Yeah. So this paper, if you the listeners have read it, it's more of an introduction paper to get people, at least we're talking on the same page. Hopefully there's more to come out of it, maybe through other researchers or maybe me and Jess do more with it. But the goal of this paper was to get people thinking about improving capacities along the rehab spectrum, from rehab to performance. Right? If we're thinking after an injury, whether post-op or acute injury, speed's going to get lost first, then power, then strength. Like you have your training residuals that go away really quick. And I was seeing a lot of younger clinicians and other clinicians just on Instagram or wherever doing these decelerative type tasks. And it seemed really low level to me for where this person is. And in my head, I was always thinking, if we address these capacities early, being aware of different tissue healing timeframes and having the right end goal in mind, that we can improve these capacities kind of like a rising tide lifts all ships. And as they transition through each phase, things are just going to be a lot smoother for them. And they're not going to look clunky or whatever when they're doing the first time doing a change of direction task or acceleration task. That is just a smooth transition throughout the entire process.
Got it. So for those that haven't read the paper, then what would you say is, I guess, your core starting point for deceleration training? Let's say that you have a client that comes in, you're like, okay, this person's ready to start deceleration training. What are some of the core concepts that you've outlined in this paper that will help the clinicians start that framework back to deceleration with their client?
Yeah, so I took so when everyone thinks deceleration, they're thinking like on the field cutting, trying to break someone's ankles. And I took it to its tenets of eccentric capacity, right? Time and tissue constraints, and just overload with force and speed. So breaking it down like that, if you in the paper, there's a framework toward the end of it where I've broken it down to post-acute stage, a load intro stage, reconditioning, and a performance stage. So with that, the goal is that depending on where that athlete is in their healing time frame, you can start introducing some form of deceleration or eccentric capacity that'll just build on each other as they are further from the timeline, get stronger, get more resilient, or at least the tissue gets more resilient. And you don't have to wait till 6 months to do something more strenuous, for example, like a cutting task. Or if they've built the capacities the entire time, you can be confident that I can introduce this now.
So Neil, can you kind of walk like a clinician who's working with athletes? Can you walk them through how you would kind of integrate this framework throughout like the course of a session? So I know like you in that initial phase there, like where are you starting these activities, within your session? What are some go-to drills or activities that you are typically implementing?
Yeah. Do you want like a specific phase or just any in general?
So I guess it would depend on the phase, but we'll just say, for your first phase here,
Okay.
is that something that you're typically doing earlier in the session because you're more concerned about like neuromuscular fatigue, or like how do you implement that? And then, what would your recommendations be to other clinicians who are seeing athletes, whether it's postoperatively or any number of lower extremity injuries, how do you feel that it's best implemented within session?
Yeah, and then it goes back to the question earlier with how this idea kind of came along. When I first started playing around with this, I started introducing just concentric and eccentric days to athletes, and then it came like as they got further along, it became acceleration and decelerative days, and then it just developed as I learned more and got more comfortable as a clinician. For someone working with an athlete, I think we need to go back to our school notes where you're learning about tissue healing timeframes, tolerance levels, all of that, right? Repair phase, proliferation. I think we lose sight in our understanding of the physiology of things. And that's where I found a lot of comfort being comfortable in that gray to progress someone. So with that acute phase, right, my real goal is to minimize the atrophy, try and maintain as much strength as they can, get the range of motion back, get firing back, just rate coding, recruiting muscle fibers. With that, if it's a post-op or even it's an acute injury, the way I'll still introduce like an overload type task, whether how much load it is dependent on the patient, but also what you can explore is the range of motion. It doesn't need to be a full range of motion activity to get that capacity built back in.
Got it. And then what would you say, some of the pitfalls that you typically see in other clinicians who are treating these athletes? Like where do you feel like people are missing the boat? And what are some, do you feel like it's mostly just that deceleration training is being implemented way too late in the game? What are some of the things that you think are shortcomings that are pretty universal?
Yeah, so that's where I really got motivated to write this paper, is that it starts late in the game, and then that most people don't address all the tenets of deceleration, right? Now we're talking about that entry speed for whatever task, which also you need to include like a length, a space constraint, a time constraint if you're trying to evade a defender or close out on someone, force through load if you're thinking about your force velocity curve, right? It's that inverted S shape. So it's a lot of force that can happen at the eccentric side more than the concentric side, significantly more. So that was my biggest use, that it progresses late or is introduced late, and that it progresses way too submax, where eccentric should not be a submax task the entire time. Maybe acutely, sure, but it has to be above max, super max, near max, all of that.
That makes a lot of sense. I think when I first started treating, I was always a little bit perplexed by the fact that, especially kind of mid to late stage rehabs, the acceleration or, a lot of the like the linear speed work that we would be doing, there seemed to be a mismatch there in the intensities relative to some of the deceleration training that we were doing. It was like we'd get somebody out on the field, we'd go really, really low intensity, like linear 3 steps and stick at maybe, 25% intensity, but then we would go work on, near max velocity with linear running. And so I completely agree with you that these things need to be kind of dosed earlier in the process. That way, when you get to some of those, mid to late stage training tasks where you're kind of up in the intensity, that they're prepared to, withstand some of those forces from a deceleration standpoint too. So I think the concept for the paper, I think, is really, really unique, and I think it's spot on. And that's also something that, I've noticed throughout my career is that, I have found myself starting to bring these into play a little bit earlier, especially in my post-op patients. So it's really cool to kind of see you put it all together in a framework like that.
I appreciate it. Yeah, exactly what you said.
All right. Brian, you want to hop on this next part?
Yeah. So Neil, one of the things that I think about a lot of times when we do mentoring with people on our platform and when we have residents is just real life case examples, right? Because I think breaking down a case example really gives context to people to help them really understand the thought process behind this. So could you maybe point to a case, and if you have a post-op in particular, I think that would be really helpful. Let's say it's maybe an ACL, for example, and they're going into, let's say, a phase 1 or phase 2, and you want to start implementing deceleration now, and then you want to progress deceleration. What are some of the things you're looking for or testing to say that they're ready to engage in phase 1 deceleration and then progress to phase 2 deceleration? Can you give us a case example?
Yeah, I mean, so ACL works a lot. So when they brought me on to Jordan Young, my goal was to just manage the entire lower extremity athlete. So my case was probably 80% lower extremity, and of that, 70 to 80% is all ACL, whether post-op or non-op. So I use this a ton with that population specifically. What I see typically is when we want to go back to running and start having those higher intensity tasks or impact tasks, right? We want the quad to be, some people say 70%, some people say 80%, and whatever time frame that is typical, which is 3 to 6 months. What I'll see for a lot of these, especially the female athlete, is that right around the 3 to 4 month mark, their quad might be sitting around like 50% of the other leg. And we're still doing some of the post-acute, the initial decelerative type tasks, like the slow tempo or yielding isos or catches, just because that's what they can tolerate. But being comfortable with certain positions, for example, I'm finding a lot if you go prone leg extension, where athletes on their stomach, hips extended, doesn't bother the knee or the patellar tendon at all, versus like a seated leg extension. So then I start playing around in that position, and I start introducing higher level decelerative type tasks, like a 2-to-1 or an overcoming or a manual resisted eccentric. And I'm seeing in these cases, 3 to 4 weeks, their quad is shooting up 30, 40, 50 pounds in just a short time frame. It's that neuromuscular overload. I should probably take a lot more videos of my athletes than I do. I wish you could see what they look like running or trying to do something, and then like a 4-week turnaround, and they look like a completely different athlete. But that's the very common scenario that I'm experiencing, is that they don't need to be waiting till 6 months to get this quad. If you start addressing a higher force and velocity task, that nervous system, that muscular system is going to adapt. And that quad is reacting really well to it, as long as you're playing around in positions that are not symptomatic.
So basically what you're saying is if you get a quad that comes in and you're testing them out and they're 70% LSI. And by the way, one thing I will say is that one thing me and Matt noticed a lot in the clinic, we have a few doctors that will refer ACL patients to us just for what they call return to sport testing, but really it's just a check-in. They might have good limb symmetry index, but their torque to body weight ratio sucks.
Yeah.
So in those cases, obviously you're still working decel because you got to bring that quad up. But are you noticing that if their quad is extremely weak, that sometimes you have to completely adjust your programming and not start deceleration work because it's too much stress?
So what I'll also do with some of these athletes, because I'll get them as a return to play consult, like they've done rehab somewhere else for 6-8 months, and I'm seeing them for the end stage because they need that higher level part where the surgeon is sending it directly to me. I'll have them on the force plates, and I'm seeing on some of these landing RFDs that surgical limb, those values are very high, 30, 50% higher than the uninvolved limb. And the way I'm interpreting that data is that they're landing really stiff on that knee,
Yeah.
even though
I would agree.
Yeah, and you can use however good of a clinician you are, you think you have the eye for it. They look great when they're doing it like a depth drop or drop jump. It looks good. But you get them on the force plates, you get the actual data, it looks like crap. And some of those athletes are still having pain, soreness, some joint swelling after the rehabs they were telling about with the other practice that they're doing. And it's not a knock on the other practice. It's just the tissue wasn't ready, that athlete wasn't ready. It was probably something along that continuum, like we talked about earlier, where they didn't build that tissue capacity early enough, and they're just getting thrown in because it's, oh, you're 8 months out, you've done all your linear speed work, let's do some cutting now. And now that knee's blowing up because that eccentric load is significantly higher on the knee. The ability to just stop and change direction and be a stiff angle. So I don't necessarily take out deceleration from them. It's more of I manage the load, right? We'll talk about the envelope of function with them. And these guys are their programming's all over the place. I peel back layers. I'm like, we're going to start at this volume of impact and decelerative tasks, and we'll go based on how your knee feels. If we have to cut back more, we'll cut back more. and we go from there. And I'll also utilize isometrics to help build just that joint positional tolerance, which has gone a long way as far as tendon tolerance, angle control, and all that.
You mentioned something. I'm gonna hop in real quick. You mentioned something that was kind of unique because that is one of the things that we see a lot of times is even on the surgical side that eccentric braking impulse numbers is significantly higher. And so I'm wondering if that is really a product of the fact that they just haven't had enough exposures or haven't been brought along far enough with that deceleration training. And so, like you said, they're landing much more stiff on that side because it almost seems counterintuitive. You know, when you get someone on the plates, you at least when I first started doing a lot of these force plate tests, I was expecting to see, you know, a significant favoring, in favor of the non-surgical limb and seeing these numbers, more heavily on that side, which we still see from time to time. And that can be a confidence thing. That can be a strength thing. Obviously, there's a number of factors that play into that. But I have been seeing a lot more where the actual surgical side, those numbers are much higher. And so you bring up a unique point that it could be, at least in part, to the fact that they haven't had the requisite amount of exposures to that deceleration training. And so they haven't, developed the appropriate patterns and recruiting. And it's just they don't have the experience there. And so they're landing harder, which, as we know, elevates their risk for, having some type of adverse, event.
Yeah, and I mean, those re-injury rates with ACLs have stayed, ever since I've graduated, have stayed consistently 20, 30%, which is, it's something I'm trying to do my part in and hopefully fixing or seeing something that can be added to what all the other researchers are doing out there to address this issue.
Absolutely.
Neil, just a follow-up point on that. One of the things that we'll typically do is we video everything. And we don't just look at just a general counter movement jump. We're looking at single leg jumps on the force plates more than ever before, because we notice that's where we can see the most discrepancy. Are you also always videoing your force plate jumps? And are you also consistently using single leg for force plate jumps?
So not consistently videoing. I probably should. I will consistently video like a 505 or a 5.2 180. I'll video those to see what their mechanics are, and I'll break it down with the athlete to say what we need to continue working on. The force plate jumping, I should probably do more of it. But my force plate battery includes the counter movement jump, single leg counter movement, a drop jump, and a single leg drop jump.
Okay, so you're using single leg then. Mm-hmm. Yeah, no, for sure. Because that was one of the things we always noticed, because the way we're set up is we have a performance side, we have a rehab side, and we work together as a group. But oftentimes they're not doing as much of the single leg work, but we are, because we find that, and we're also videoing things because we find that there's a discrepancy a lot of times in what the quad output is versus a force plate jump or a counter movement jump. We don't always see the exact discrepancies like we see for more of an isolated jump or more of an isolated quad test. So we also tend to just roll through with a lot more single leg work for video purposes for the single leg jumps. And we find that seems to be a little bit more effective to help us really see what's actually going on in those patients' knees.
Yeah, and trying to break down their pattern and adjust their programming moving forward. So when they retest, everything looks smooth.
Correct.
Neil, what advice would you give a newer clinician who's trying to implement this framework that you've put together, who may not feel, tremendously confident with some of the technical aspects of it? Are there certain drills that you feel are a good entry point, or things that that you would, any recommendations or advice that you would give to somebody who, this is a brand new concept for?
Yeah, I mean, you can definitely go in the rabbit hole of deceleration and change of direction, right? I mean, there's like that science of multi-directional speed and all of Damian Harper's work and Dos Santos's work. And that's a huge rabbit hole, and any younger clinician or newer or clinician trying to look into this can lose their mind, pull hair out for that. I mean, that's what I did that as I was writing this paper. I was like, this is just so much, and I'm trying to synthesize all this, trying to make it easy for someone to read. But for that, I think I would go back to the tissue healing timeframes. I did a presentation in Massachusetts for an NSCA state clinic, and that was my big talk, was about understanding loading strategies based on where the tissue is. And if you understand where the tissue is and what capacity have been built and what has been lost, I think gives you more confidence to push where you can. And if you understand what symptoms, going back to the envelope of function, show you that you're doing too much, then you just scale back. And then, I mean, that scale back can be anywhere on that framework continuum that I put out in the paper. So maybe if someone that's starting out for the first time, even if this athlete's 6-7 months out, they start with the post-acute or the load intro stuff first and see how they can coach it, they can demonstrate it, how the athlete looks doing it, how the athlete responds to it, and go from there.
And then another quick follow to that. I know Brian and I have certain parameters that we look for when we're assessing tolerance to something, some type of novel task. But when you talked about, kind of monitoring them to see if they're responding well to some of these deceleration tasks, what are the things that you're looking for? Do you have certain cutoffs that or benchmarks that you adhere to with regard to like numeric pain rating scale or onset of edema? Like, what are the things that you typically are checking on to make sure that you can keep pushing this forward, pushing this person forward within this framework?
Yeah, great question. What I use is the pain scale is 1. I say 3 and less, we're good. Body's going to adapt in a way we want it to. 4 is the gray zone. If you want to push with it, we can. Anything more than a 5, we got to cut it, or I got to change this task somehow. Either slow entry speed, slow velocity, change the task completely, but you got to let me know. The other ones is the edema and the joint soreness. I just follow a 24-hour rule. If it lasts less than 24 hours, I think that's enough the body's adapting to that I'm happy with. If it lasts longer than that, then I push too far outside the envelope. And I usually give my athletes, I draw the diagram of the envelope of function on our first visit or second visit. So we're speaking the same language and there's some sort of rapport that I can trust them and they can trust me that we're still going to progress you where you want to be. It just, if we keep pushing outside into that failure zone, we're not going to get you where you want to be in a time, right, in a time that you want.
Sure. Cool. No, that makes sense.
Neil, I have one follow-up question to those things too. So a lot of times when we're introducing deceleration work, we're also not stopping the concurrent training, meaning that we're still weightlifting, we're still working on acceleration, we're still maybe introducing maybe a level 1 change of direction depending on how far they are into that deceleration phase, right? Let's say they're through phase 1, they're probably starting some type of change of direction components. When you're working with athletes and thinking about all those things, because I think a lot of younger clinicians get bogged down and say, I got to get this done before I can do this. Meaning I got to get all my deceleration work, then I can do Excel, then I can do change of direction. But we know we have to do all of it at once, concurrently in some capacity. How do you schedule that out throughout your week with athletes in your setting, and how would you recommend it for others that have to work with athletes every single day but have to get all these tasks done?
Yeah. So for me, I see most athletes twice a week. I work just 4 days, so twice a week works really well for my schedule and their schedule. But then it goes, I do Excel or concentric focus day and a Decel eccentric focus day. So there's one day that's purely meant for one of those capacities each day. And then the programming follows it. The weightlifting part follows underneath. So they'll come in, do their dynamics, and they'll do their prep work. And then whatever high neuromuscular or cognitive tasks I have for them, whether it's learning certain patterning for acceleration or deceleration, that's pretty high up in our list of things we're doing in order. And if it's a high velocity task, it's pretty high up. And then from there, so like our jump training and our speed training is pretty early on in the session. And then after that, all my loading strategies as far as weights go and bands and accommodating resistance, all of that follows those capacities that we're training that day. So if it's an eccentric day, I'm doing tempo work, I'm doing like a accentuated eccentric loading, I'm doing bands, whatever. And then if it's a concentric day, I'm playing around with seated starts or propulsive tasks with the weights.
And do you find that as you're ramping up week to week that you have to adjust your volume and intensity on certain components so that you're not getting that neuromuscular fatigue? Because that's the problem that we've run into at times, is that we have this ramp up, and we're ramping up deceleration, acceleration, change of direction, weightlifting, and then sport specific work. We always have to kind of scale back on certain things in order to let the other one continue to move up. In those cases, what are you looking for to adjust, and how do you make that decision?
Yeah, I mean, the easy decision I'd used to do was with the counter movement jump. If that concentric impulse or eccentric duration was going the opposite way than what we want, that there's some sign of neuromuscular fatigue right there. So I may just give them a deload week. Some of these high school kids, college kids have spring break coming up. So I'm like, you're not training at all. You just go enjoy your vacation. Just relax. We'll come back and hit in. Those numbers go up, which is great. But if that break isn't there, then I'm scaling back. Maybe I'm scaling back. I'm not doing decel work as far as field work and jump work and loads. I'm taking out one of those. So there's less of the fatigue. I'll go based on what I feel is the lower hanging fruit that will go the longest for them.
Okay, so basically that counter movement jump you're doing every week to allow yourself to have something to gauge off of to see how they're doing.
Mm-hmm.
Is that what you're saying?
Yes.
Okay, correct. Got it. Matt, you got anything?
Yeah, quick question. So I know you said that the majority of your caseload is lower extremity, and obviously within the framework that you've built, this is, for your lower extremity athletes. Are there certain athlete types or certain injuries or surgeries where you feel like this framework has, in your experience, has succeeded the most? And on the flip side, are there any tricky cases where you feel like this framework was a little bit more difficult to implement?
Yeah, I mean, the knee one is a really easy one that I mean, this is what it was built off of, was knee injuries. So it works really well with that population. I do see some shoulders, and be a little bit more creative with the shoulders as far as introducing it, but they respond pretty well. The ones I've been having a difficult time with lately are these calf strains. They're just very sensitive structures they have a different capacity that I don't know if I understand well enough to introduce the decelerative work that I want, where without the calf getting so symptomatic.
Got it.
Okay. Yeah. So let's wrap this up, because obviously there's been a lot of great information here, Neil. After somebody reads your paper, what are your next suggestions for them to continue on the path of just understanding deceleration a little bit better? So they read your paper, they understand the framework. They're getting excited now because they're reading this paper. What's the next step that they can take?
The next step, well, so I know Jess has talked to me about making some videos based on the paper, so I got to do that. So I know those videos come out, they can watch those, but honestly, it would be probably trying them out with some of their higher level athletes, because there was that capacity for that athlete's going to be pretty well, and the tolerance will be high, and explore it themselves too. Deceleration is such a dark side of the moon thing that not enough research papers talk about, right? It's very accelerative based, or biased rather. That's where I was like, I need to write something here. So them exploring these tasks themselves to see how it feels, to see how they want to coach it, and what the intent should be out of those exercises, what I think should be the next step for them.
Got it. And everything that we've talked about today, if you were to say one takeaway, what would that be?
Ooh, one takeaway.
One takeaway from this episode, what would you say is the most important thing that you think that we discussed today?
If you are confident in your heuristics and frameworks, don't be afraid to explore and push movement.
Awesome. Good stuff.
Okay.
Neil, tell us how people can find you. What's the best way to get connected with you, to learn from you, to get in touch with you?
The best way is just Instagram, N1 Sports Rehab. It's the letter N and then the number 1, Sports Rehab. DM, message, anything. That's the easiest way.
Awesome. Neil, thanks so much for joining us today, man. It was great to chat again and see you after that conference and learn a little bit more about deceleration today.
I appreciate you guys having me on. Hopefully it enlightens someone or lights a fire in someone like it did me to write some paper and push it even further.
Yeah, man, you're doing great work.
I appreciate it. You guys are too kind.
All right, man. Take it easy.
See you, man.